So a 17-year-old student came with a history of a fever, a sore throat, and cervical lymphadenopathy since 2 days. And he was started on a capsule augmentin, that is a amoxicillin with a galvanic acid, by a doctor. Later, he presented to the emergency department with the rashes all over the body. He had a rheumatic fever. See the question that stated the patient have a rheumatic fever in the past and taken oral penicillin prophylaxis, that is for all of might be for the years, and he got a good vaccination history. The question stated that the student got a good vaccination history, and what is the possibility for the rashes? See, he have a fever, sore throat, cervical lymphadenopathy, and he started on capsule augmentin, and later he presented to ED with rashes over the body. And also the question states that he got a good vaccination history, and for the rheumatic fever he has taken the oral penicillin in the past. So he came with the rashes all over the body. So what is the possibility? We have an option of Steven Johnson syndrome, a glandular fever, adult still diseases, and rubella infection. And the answer is going to be the before. Okay, I'll let you the answer first. That is a glandular fever, or a EBV. That is a EBV virus. That is Epstein-Barr virus. That is a human herpes virus type 4. It is characterized by the fatigue, fever, pharyngitis, and lymphadenopathy, and it is spread by the droplet and saliva and kissing. This is mostly common in the students. That is why it's called a kissing disease. And EBV is a cause of heterophile, that is a positive infectious mononucleosis. It is characterized by a fever, sore throat, and lymphadenopathy. See, this EBV is the cause of heterophile, that is a positive infectious mononucleosis. This IM, that is the infectious mononucleosis, is going to characterize by the sore throat, fever, and lymphadenopathy. See the question, we have a sore throat, fever, and lymphadenopathy. So it is going to be a glandular fever. And keep it in one mind, if we take a penicillin in this cases, for the cases with the EBV virus, we should avoid the penicillin, especially the amoxicillin, because it's going to be produce the rashes. So that doesn't mean that patient not allergic to amoxicillin, because the question itself stated that he got a good vaccination history, but only this amoxicillin, it is going to produce a rashes. See, why it not be the Steven Johnson syndrome? Because it's not going to be Steven Johnson syndrome, because he have taken a penicillin prophylaxis, and also he stated a good vaccination history. So rubella infection is also not going to be there. Adult cell disease is another condition, that is also a fever with the rashes, but in that adult cell diseases, there will be the increase of a degree. There will be a higher degree fever with rashes, but the rashes going to disappear after the episode of fever. So this is characterized by the adult still diseases. There will be the fever with rashes, and there will be a onset and the sudden onset of the degree, and the rashes will disappear after the each episodes of the fever. That is characterized by the adult diseases, and the answer is going to be the glandular fever or the Epstein-Barr viruses. It is characterized by the fever, pharyngitis, and lymphadenopathy, and it is the causes of this EB virus is the causes of infectious mononucleosis. It is characterized by the fever, sore throat, and lymphadenopathy. See, a 38-year-old male patient present with a 2-day history of a localized pain and tenderness in a leg. See the localized pain and tenderness in leg. What is the appropriate management of the condition? We have NSAIDs, that is a non-steroidal anti-inflammatory drug, antibiotic, anticoagulation, bed rest, and compression stocking. Oops. When coming to the pharmacology, then it will be the most like. There is a self-suicidal, uh, that particularly for me when coming to this pharmacology. We have the options of NSAID, antibiotic, anticoagulation, bed rest, and compression stocking. See, this patient is have a tenderness and pain, that is the superficial thrombophlebitis, maybe because of injury, or sometimes due to the IV line also, it may be the cause of IV lines. The patient can have redness, tenderness over that areas, and normally when they mention only the pain and tenderness in the leg. So if the normally it is a DVT, that is a deep vein thrombosis, any thrombosis, we can use all these kind of the NSAIDs, antibiotic, anticoagulation, and compression along with the stocking, and bed rest also, because we need to, in DVT case, when we have to elevate, so because of the compression stocking. See, now they have mentioned only the localized pain and tenderness in leg. It is a what is the most appropriate management? Warm compression can be given, but not with the stocking. So that is, the compression and stocking will not going to be the answer. Antibiotic can be given, but only in the infection is leader. But they said only the pain and tenderness. There is no any infection or over anything. Only pain and tenderness over that area. That is a thrombic superficial thrombophlebitis, and there is no, if any infection due to that, we can give antibiotics, so there is no infections also. Anticoagulation and bed rest is not recommended, because that is not going to be the bed rest, and anticoagulation is not going to be recommended. The answer is going to be the non-steroidal anti-inflammatory drug. Some are relatively recommended, but this answer is going to be the NSAIDs. How? This antibiotic, because there is no infection, and anticoagulation is not recommended at all, and compression can be given, but not with the stockings. A 50-year-old diabetic patient. See, the diabetic patient came with a severe acidotic and breathing low in the GCS. And the serum ketones are positive. pH is 7.2. The potassium level is 2.2 milliequivalent per liter. And the blood sugar is 86 milligram per deciliter. And the X-ray shows there is in the right lobe there is a few infiltrates. So what is the sequence of treatment? Say they have given all the treatment modality, and they have to ask the what is the sequence. They are asking to arrange in order. What is the sequence of treatment? We have insulin infusion, normal saline infusion, potassium infusion, and antibiotics. So everybody understand from this, it is a diabetic ketoacidosis case. There will be the acidotic and the ketones are, so serum ketone is positive, so thereby we can understand it is a diabetic ketoacidosis case. This patient requires everything. There's a insulin infusion, normal saline infusion, potassium infusion, and antibiotics also. Most important in the patient with diabetic ketoacidosis, the patient might go under dehydration. So first is water loss. The patient is a water loss, so we need to rehydrate. The patient might lose 6 to 8 liters of water per day. So for that we need to correct the dehydration. For that we need to rehydrate. Then only we need to go for the potassium and insulin infusion, and then antibiotic. Of course we are going to go with all this: insulin infusion, normal saline infusion, potassium infusion, antibiotic. First of all, when coming to the diabetic ketoacidosis, the patient undergo severe dehydration. First we need to correct the dehydration. For that we need to correct it, we need to rehydrate it. So then only we are going to start, if there is any decrease in the potassium level or any insulin level, then only we are going to that. Of course we are going to give antibiotic also. The sequence of this treatment is going to come along with B, C, A and D. The answer is the origin of B, C, A and D. It's we're going to start the treatment in the option of normal saline infusion, because as I said, the person is going to be dehydration, so we need to correct it. For that we are going to give a normal saline infusion, and then we're going to potassium infusion. See, in this there is a 2.2 milliequivalent liter. See, if the potassium level, if the serum potassium level is less than 3.5 milliequivalent liter, we need to correct the potassium first before we are going to start the insulin infusion. Keep it in mind, when the patient is a ketoacidosis, first thing we need to correct the dehydration, that is we have to saline infusion. Then in the question there is if the potassium level is normal, then we can go for insulin infusions. In this question we have stated 2.2 milliequivalent per liter. If the serum potassium level is less than 3.5 milliequivalent per liter, so we need to give a potassium infusion. After correcting this potassium, So we going to the insulin infusion, starting from the low dose, that is international 10 unit or 0.010 unit, and according to the sugar level we need to titrate it, and followed by the continuous IV infusion. And for, first we have to start with the low dose, that is 0.10 unit or 10, that is according to the sugar level. Later we are going to titrate it, and for continuously followed by the IV infusion. Then we are going to have an antibiotic, because he got an lesion on the lung. Says that there is a there is a right lobe, and there is a few infiltrates. There is a got infusion, got lesion on the lung. So we have to select a correct antibiotic. For example, levofloxacin and piperacillin tazobactam. Accordingly to the see the treatment diagnostic, the drug choice is depending upon the X-ray findings and clinical findings. For example, I am saying levofloxacin, piptas, that is a piperacillin tazobactam. So we have the order of treatment is going to be under first normal saline infusion, then the potassium infusion, then insulin infusion, then we are coming for the antibiotics as the patient got a lesion on the lung. There's a few infiltrate in the right lobe, right lower lobe.